Today we'll return to Chapter 19 for another look at the cardiovascular system. In Part 1, we studied the actual blood vessels, the anatomy of the blood vessels. Now let's learn about blood pressure, flow, and resistance. So what is pressure? We've talked about it a million times already and never given a fair explanation. Pressure is the force per unit area exerted on the wall of the blood vessel. So when you think of the blood being forced into a vessel, stretching its walls, that force of the blood pushing on the walls for every square centimeter of area is the pressure in there. It's pushing outward. We use millimeters of mercury. That's the units of pressure. And it's because of a type of manometer or pressure measuring device that was used early on in the study of pressure in the vascular system. When we say blood pressure, we really mean systemic arterial pressure. We shorthand for just blood pressure because that's the only place we typically measure blood pressure and consider its impact. So remember, this is arterial blood pressure and really systemic. We're not talking about the pulmonary system. We'll just say blood pressure, or later we'll say mean pressure. What makes blood flow? A difference in pressure from one place to another. That's what moves blood. So the sole purpose of the heart is to raise the pressure up higher at the heart than anywhere else in the system so blood will flow down through the rest of the vascular system. It's the sole purpose of the heart. Force blood out into the arteries, stretching their walls, raising the pressure. So flow is the volume per unit time, mils per minute, or liters per minute of blood flowing through a certain part of the system or the entire circulation. When we're talking about the whole circulation, we often call it cardiac output, and we've seen that before. Total amount of blood the heart is pushing through the system per minute, liters per minute. Resting, a good textbook value is 5 liters per minute, which can jump up to 35 liters per minute during exercise. And we actually already defined that in the last chapter. We said that difference, that 30 liters per minute increase, is called the reserve, cardiac output reserve. But local flow, sometimes we like to talk about the flow in the liver, or the flow in the heart, or some other organs, and then we often talk about milliliters per minute. And what we're talking about is a flow that's exactly tailored to the metabolism in the organ. And this part of this chapter will be to discover how does that work? How do we get the flow to exactly match the demands of the tissues? Pretty good. Okay, so flow is driven by a pressure difference, we said. That's what the delta P means, a difference in pressure between two spots. The R stands for resistance. Its blood flow is opposed by what's called the peripheral resistance. How hard is it for the blood to push its way through the vessels? There's friction in there. And the friction gives rise to this opposition, this peripheral resistance. It depends on the blood vessel diameter, as we'll see in a minute. The narrower the vessels, the harder it is to force the blood through, the higher the resistance. The greater the diameter, the lower the resistance. So let's take a closer look at resistance. What impacts resistance? And as I mentioned, diameter. I just want to show you this formula. This is a proportionality relationship. If something on the left goes up, then the right will go up, and vice versa. They're proportional to each other. So resistance, the opposition to flow, is related to the viscosity. How thick is the fluid we're talking about? The thicker it is, the harder it is to force it through the vessels. You can just imagine if I had two identical funnels and put water into one funnel and let gravity pull the water through and poured honey into the other funnel, exact same volume of honey, you can just by gut feeling realize that the honey will take way longer to go through. It's more viscous. So there's a resistance to flow there. The length of the plumbing. The longer the distance of a tube you try to push blood through, the greater the resistance. It's harder work to push blood through a longer vessel than a shorter one. And that's actually related to the total amount of tissue. So if you add a lot of adipose tissue to your body, you effectively increase the length of the vessels and your blood pressure will go up. Resistance will go up, I should say. Now let's look at the radius. How wide are the vessels? The radius to the fourth power is inversely related to resistance. Inverse just means it's on the denominator on this side. So if the radius of a vessel goes up, the resistance goes way down. It makes a huge impact because of this fourth power term. Let's go take a look at that. So if we constrict the blood vessels, let's say we reduce the radius or diameter to 1/2, the resistance goes up 16 times, right? Small change in diameter, huge change in resistance. If we dilate the vessels, so we double the radius, now the resistance drops 16-fold, or to 1/16 its original value. So small changes in diameter make all the difference in resistance. And that's exactly how we control flow in blood vessels, flow in organs. So when we're thinking about arterial blood pressure, we know it's pulsatile, right? When the heart rests, the blood pressure falls in the arteries down to as low as 80 millimeters of mercury pressure. Then the heart does its job, raises the pressure in the arteries back up by forcing blood out into those arteries and stretching their walls. Now we have systolic pressure, 120 millimeters of mercury. Back down to diastolic pressure as blood flows away through the system. The elastic walls of the arteries pushes that blood through. The heart does work and stores energy in the form of stretched elastic walls of the arteries. And when the heart rests, that's when 2/3 of the blood gets pushed through the circulation amazingly. So the blood vessels act as potential energy, and when the heart rests, they continue to force the blood through. Right, we've got a high pressure over here, and then as we travel through the arterioles, look what happens to the pressure. It drops precipitously. That big drop in the arterioles is because the arterioles have the greatest resistance of any part of the circulation. That's where we attack. That's where we make changes in order to control the hemodynamics, the flow and pressure of blood. So we can change the radius of the arterioles, the tiniest arteries, less than 1 millimeter diameter. That makes all the difference in terms of total peripheral resistance. So this is the spot. Oftentimes when I talk about vasoconstriction, I'll just talk about arterioles because it's so important for talking about resistance and blood pressure. But remember, arteries have smooth muscle, they constrict. Veins have smooth muscle, they constrict. The arterioles have the most impact on peripheral resistance. So, right, we just look at systolic pressure and diastolic pressure. The difference in the two has clinical diagnostic value. So the difference between diastolic pressure and systolic pressure is called the pulse pressure. How much difference? It's that throbbing. And the stiffer the walls of the arteries are, the greater that pulse pressure is going to be. The heart will pump out exactly the amount of blood the body needs for its metabolic demands. Let's say 70 mils per beat at rest. Well, if that same 70 mils has to be pushed out into a stiffer blood vessel, the systolic pressure is going to rise higher as the blood forces that blood out into that less stretchy artery. So pulse pressure will go up if the wall is more stiff. What could make the wall more stiff? Well, contracting the smooth muscle. If the person is very vasoconstricted, we can just take a look at the pulse pressure and make a guess about that. It makes the pulse pressure high. Atherosclerosis, vascular disease. The harder the arteries get, the more diseased they become, the stiffer they get, the higher the pulse pressure. Or, if we, during exercise, start pushing more blood volume out into the arteries, think of what happens when you blow up a balloon. As the volume goes up, it gets stiffer and stiffer to where you're afraid it's going to pop. It's really stiff. That's what happens to your arteries. If you force more blood out, if you raise the contractility, raise venous return, and force more blood out each beat, it's going to stretch the walls and make them more stiff, and the pulse pressure is going to go up. That's a normal finding. So, pulse pressure. I drew in some, right? If you look at these green lines I drew and took the average, figured out the mean pressure between resting or normal diastolic and systolic pressure, and then took the mean of these two new diastolic and systolic pressures after stiffening up the arteries, you get the same mean. So if you look at an average pressure, you'd say, oh, everything's fine. But the pulse pressure would give away that something's going on. All right, so let's think about arterial blood pressure, mean arterial blood pressure. We use that term because we have this pulsatile pressure, but the average driving force, the driving force pushing blood through the vascular system, is kind of the average over time of these two, diastolic and systolic. Sometimes it's easier to think about one number. So we figure out the average. So we start with diastolic pressure and add 1/3 of the difference. In other words, we start down here to find the average and we move up 1/3 of the way. We call that the average. Right? If you took a true average, it would be half of the way. That's how we normally do an average. We take the two numbers and we divide them, add them and divide in half. We're not doing that here because the pressure spends a little more time, based because the shape of these curves, this pressure spends a little more time closer to diastolic pressure on average. So the true mean pressure is about 1/3 of the way up from diastolic pressure. So our formula is diastolic pressure plus 1/3 of the pulse pressure, 1/3 of the difference. So in our typical example, 120/80, we get 93 millimeters of mercury. That's a good textbook value for mean arterial pressure. So the next step we're going to take is to try to look at the variables that impact mean arterial pressure so we can have the basis to understand how it's governed or regulated. So let's look in on that. What determines mean arterial pressure? What factors? What variables? So let's start out with our flow equation. We've looked at this before. Incidentally, there's a very famous relationship called Ohm's law. The exact same rule applies to electrical potential difference instead of pressure difference, current flow of electrons, and resistance to current flow. So this is Ohm's law. It fits very well here. The flow of blood is driven by a difference in pressure between 2 points, and it's opposed by the resistance. So if we just rearrange this, solve for delta P, the difference in pressure we're talking about, delta P equals flow times resistance. Now, what is delta P? It's P arterial minus P venous. Right, in this case, we're talking about the difference in pressure across the whole vascular system. You raise the pressure at the heart, and it gets lower and lower and lower as it travels all through the system back to the heart again. So start out high at the heart and drops all the way through. So we're just looking at the difference between those two. So now we can say, well, you know, the venous pressure is so low, we can just ignore it, right? If arterial pressure is 120 millimeters of mercury, or the average, 93, and the venous pressure is 0 or 2 millimeters of mercury, we'll ignore it. We're just going to make this equation a little simpler. So now, if we call arterial pressure mean arterial pressure, we haven't changed anything, just using a different term. Mean arterial pressure equals flow, and if we're talking about the whole system, flow is cardiac output, right? And then resistance, the peripheral resistance. So this is a wonderful formula that can help us really begin to understand the things that affect pressure. One more step. Cardiac output can be calculated as heart rate times stroke volume. Right? The number of beats per minute times the amount of volume per beat, boom, total. So now we substitute that in and we have this wonderful formula that describes stroke volume impacts blood pressure, heart rate impacts blood pressure, resistance impacts blood pressure. So if any one of these three things goes up, mean arterial pressure must go up. If any of these things goes down, in the absence of any other changes, then mean arterial pressure must go down. So that's a really, really useful equation. I want you to just know that in your sleep. Memorize that equation, seriously. You should almost have it on every slide now from here to the end, just to remember it. I want to mention something else about resistance that we haven't talked about. It wasn't in our original formula. Laminar flow is how blood normally flows through the vascular system. And I'll show you a diagram to illustrate what I mean. All the blood cells and water and everything are flowing in a straight line smoothly along through all the blood vessels, like a whole bunch of people walking together in the same direction. Turbulent flow is a violent flow involved with lots of swirling and eddy currents and things. And when flow becomes turbulent, it's very hard to push the blood through the blood vessels. What happened? Why is this? Why does this happen? Because of a rough surface or high velocity of flow. So let's look at laminar flow. Here's some blood flowing through this cylindrical vessel, and I've used arrows to represent the velocity. How fast is any one sort of chunk of that blood flowing? In the center of the vessel, it's moving the fastest. At the edge, on the surface, there's kind of friction there, and so the blood kind of slows way down at the surface. And so we have a parabolic distribution. Here's a parabola that just means if we just look at all these arrows and create a graph of the tips of the arrows representing velocity, we get this parabola. So the flow is fastest in the center and slowest at the walls, and it's sort of graded all between. That's laminar flow. Everybody's moving at different speeds, so all the units of blood have to flow past each other without any arguments. If you push the velocity too high in any given situation, all of a sudden that friendly flow, where all the layers essentially, think of cylinders of blood moving through here at different speeds, they crash. And the blood just goes swirling through the vessel. And the problem with swirling or turbulence is sometimes blood is flowing forward. And sometimes blood is flowing straight towards the wall. Sometimes blood is actually flowing backwards, units of blood. And so you can see that that's going to be way less overall movement of blood through the vessel. So it's very hard to push the blood through, as much blood through, because some of it's moving in the wrong direction all the time. So turbulent flow, if you have a stenotic valve in the heart, for example, you try to force blood through there, you've got to force it at very high velocity because it's a very narrow opening. What happens? Turbulence. What do you hear? A heart murmur, because you can hear the violence of all that swirling happening. All right. So that increases resistance if you get turbulence. If you have atherosclerosis, it creates rough surfaces on your vessels, and it creates turbulent flow, and it works the heart to death. Even if the mean arterial pressure seems relatively normal, the amount of work the heart is doing, it probably won't be able to be higher because the heart has to force the blood through this resistant vessel, this turbulent flow vessel. Now let's move to the capillaries. We spent enough time on arteries for the moment. The capillary blood pressure is much lower, and it actually drops off from one end of the capillary to the other. It comes in around 35 millimeters of mercury, and as the blood flows through the capillary, it drops off to around 17 millimeters of mercury. It's good to have lower pressure here. We need to protect those capillaries. The arterioles are right there. They're the resistance vessels, and the pressure drops. And that's to keep those poor little delicate, microscopic capillaries from getting busted up and overly stretched. Capillaries are permeable to water somewhat. All the time there's a little bit of water oozing through the walls of your blood capillaries. The greater the pressure in the capillaries, the faster that water gets pushed out. The lower the pressure, the slower the water gets pushed out. So when blood pressure goes up, water starts leaking out of the system into your tissues. So that's an interesting point. If the blood pressure goes up, water starts leaking from your blood vessels into the tissues. It can even form swelling called edema. How about in the veins? In the veins, the pressure is even lower, right? We said that the capillary pressure is down to around 17. The blood enters the veins, drops to about 15. And as the blood flows to the veins, it drops to maybe 5, 4, 0. Very, very low pressure. How in the world can a difference in pressure, say at the start of the veins of 15 millimeters of mercury, and even if it drops down to as low as 0, that's 15 millimeters of mercury difference, how can that drive 5 liters of blood per minute through those veins? Or what if it's exercise? How can it push 30 liters per minute through those veins? So we got to figure out what is it. There's some things going on there that help us get the blood through the veins with a very small pressure difference. Right, let's look again at the veins. Right, by the time we get out of the capillaries, there's been another pressure drop because there's some resistance there. Then we come to the veins. We're way down here. The difference in pressure across the veins is only like maybe 15 millimeters of mercury at best. So what are we going to do? Well, there's a number of features that allow that to happen. Muscle pumping. During exercise, typically, you get a huge boost in venous return, blood flowing through those veins, Every time you contract your muscles, even if you're not really exercising, just moving around doing something, every time a muscle contracts, it wrings out the blood from the veins that are inside the muscle tissue, and the blood can only go forward. Whenever a muscle contracts, blood is forced back towards the heart because veins have one-way valves that won't let the blood go backwards. So every time a muscle contracts, blood goes forward. And the more you exercise, the more vigorously, and the more muscles that are involved, the greater the return of blood towards the heart. Venous return, of course, we call it. The valves keep the blood going forward. When you inspire air, the way you inspire air or breathe is to lower the pressure of air in your thorax, and air moves for the exact same reason as blood, differences in pressure. So if you lower the pressure in the thorax, air will move in from higher pressure outside the body to lower pressure in the thorax, and you'll have breathing, you'll have ventilation. But lowering the pressure in the thorax also draws blood back to the thorax from every which way. And so that blood is coming to the heart, and it can never go back, of course. When you expire air, the opposite happens, but the blood can't go back because there's valves in the veins. So the more deeply you breathe during exercise, the more you draw blood back to the heart, increasing venous return. And finally, veno constriction. We said in part 1 of this chapter that about 2/3 of the blood volume is in the veins as it's on its way back to the heart. So that's a lot of the overall blood volume. And if you just constrict a little bit of smooth muscle in the wall of the veins, you push a whole bunch of that blood right back to the heart. So sympathetic nervous system activation causes increased resistance in the arterioles, but it also causes veins to constrict, pushing a lot of blood back to the heart. Huge increase in venous return. There's a little illustration of muscle pumping. I don't know how good an illustration it is, but hey, it's a visual nonetheless. So, summary of factors that affect cardiac output. Oh, that's good. During exercise, we just looked at some things that increase venous return. Muscle pumping, you increase the action of the respiratory pump. Right at the top, I pointed the wrong thing. The more you exercise, but this works even at rest. But during exercise, even more so, increase venous return, increase diastolic and diastolic volume. Now, look, here's a little faux pas. These are not two different things that one affects the other. These are synonyms. So your authors were in error, or the artists, for drawing these as two separate boxes. You should make a separate box around both of these. We're going to increase venous return, which is end diastolic volume. And when you do that, you stretch the ventricle wall. Frank-Starling law says the stroke volume will go up. Firmer contraction. If stroke volume goes up, cardiac output goes up, because cardiac output equals stroke volume times heart rate. Let's say we have a drop in blood pressure in the chest. That's going to cause an increase in sympathetic output because of the baroreceptor reflex. Remember, we talked briefly about the baroreceptor reflex, and we'll bring it up again next section. That causes action of sympathetic neurons, which increase heart rate, increase contractility. Sympathetic nervous system, I should have said right here, what's causing that? Epinephrine and norepinephrine. Sympathetic neurons to the heart, epinephrine in the blood, acting on those same receptors in the heart and the blood vessels. We're going to get an increase in a decrease in end systolic volume, increase in contractility. Pump out more of the volume of blood. If you pump out more blood, you're increasing stroke volume. The sympathetic nervous system causes an increase in stroke volume by force. Increasing venous return causes an increase in stroke volume by Frank-Starling law. And finally, epinephrine and norepinephrine both increase heart rate, acting on the SA node, AV node, and increasing heart rate increases cardiac output. So just wanted to follow along one time together with you on that diagram of the summary of things that we've talked about so far. I did want to make sure we don't leave out an important thing. Exercise activates the sympathetic nervous system. The longer and more intensely you exercise, sympathetic activity rises the entire time and rises in proportion. So it doesn't just get activated when the blood pressure falls. Exercise induces sympathetic nervous system activity. So just to clarify that, remind you. So contractility goes up, heart rate goes up, and boom, we have a huge increase in cardiac output, right up to 35 liters per minute. All right, so join me next time as we talk about how do we regulate blood pressure then? We now know all the variables. Let's see how we regulate it. We'll talk about abnormalities when your blood pressure is too high or too low.